Thank you very much. I'm Phil Polikoff. It's a great pleasure to be here, and I can't express my gratitude for the Center for what they're trying to do on this subject. A special note for David, I'm a little concerned because one of the things he shared with me last night, didn't share with you today, is that he did his first high school debate here in Yakima. Okay? And with Bruce, who I hold in high esteem, Bruce is from Boston, and I'm from New York, and we actually tolerate each other's behavior under a Chatham agreement, so we're there. For this session, we have an incredibly talented group of people arranged across the entire continuum between those in an academic setting, to those in the clinical setting, to those in the training setting, to those who are trying to facilitate the future of healthcare delivery. So each one of them we'll get to, and we're going to do it in a specific order to see if we can get through it. So we're going to start off this panel. If it's a panel, I want it to be as interactive as possible. I want it to be as grounded as possible, so all of you are going to have a chance to go after each other before the audience is going after you. And keep in mind, I'm wedded to the word healthier, not just health or healthcare, because all these issues are all intertwined. And when I look at a healthier rural West, and we'll get into it, I see 5 major issues there that are critically important. Health and wellness, poverty, education, prosperity, environment, society, culture, and media, and governance and policy. And it doesn't matter if it's the stuff we heard on fire suppression and prevention or anything else. Somehow we got to get the voice out there. And as Bruce was saying over and over again, I would agree with him, I'd put it right in the middle. Convene, collaborate, and commit. It's more than just collaboration, it's commitment. So with that, I'd like to show you the video that Vlad, who's the videographer, and Jeff helped create last year in Santa Fe that set the story in motion on the healthier rural West. Then I'd like to go over real quickly a few slides to ground the foundation for what we're going to do. And then we're going to start with our first person, Badisha, and then we're going through these elder esteemed gentlemen who are all dressed in a very professional manner. Sorry, Kevin, I wish you had a tie on to match the standard that the bow tie meets with the people at the end. But we're going to have fun too. So let's let it rip. We got the video going? And then there's a voice that's going to come on screen, our esteemed colleague from the University of Washington.
However, before we get to that, thank you so very much. I'm sure most of you have other thoughts going forward now, and you're on the move. However, before we get to that stage of departure, we want to share with you what you shared with us. And hopefully we can take the experience over the last 2 days and not say that this is the conclusion for today, but a start for tomorrow.
Well, I do think healthcare, which is the subject of this conference, is a critical issue. Communities in any part of our state really can't survive and prosper without good healthcare services.
The amazing thing about Earth's beauty is that as much as it erodes under human influence, it remains inexhaustible. There is great beauty even in abused landscapes. It is a good thing for all of us to dedicate some part of our life to the defense of Earth's beauty. If you believe in sort of the existentialist credo that through right action you create meaning, well, to act in defense of Earth's beauty is meaningful.
I think from my perspective, the critical issue is the interrelationship between poverty and the life conditions that people have in the rural West.
A quick response is quite difficult. Right now, we're seeing that a healthier rural West is more a dream than a reality. You're getting a feeling that there are more people who are committed to change. So there's a hope. I'm very excited about the potential. The people who presented were diverse, had differences of opinions, had a passion for commitment, how much they're willing to step up to the plate and take a swing and said, I'm in, only time will tell.
So in New Mexico in particular, access to care is pretty critical for us. We operate with a predominance of rural communities, and having people not able to receive critical care at important times is something that we're challenged with.
What generates a lot of excitement in faculty members like myself is watching students and residents say, aha, wait, I can do this. That broader perspective we teach is not just what happens in the state capitol or in Washington, D.C. It takes place right where they work.
All of us ought to be concerned about water issues in the West. All of us ought to be concerned about greater opportunities to exercise and take advantage of the amazing geography in which we live.
One of the things I keep hoping is that the Lane Center will become a resource. What the Lane Center does, what their staff do to put this on, and the people that come and participate, and the amount of passion and interest is really rewarding.
I think the most important issue is the fact that the United States as a whole does not understand that there's a serious health problem in the rural West. We got plenty of policies. How do we execute and make the policies work better? That's an area where I think Stanford can help. There's typically not enough attention on execution. That's where we need help. That's where I think Stanford can lead.
One thing we do at SAR, even though we're deeply rooted in the Southwest and in northern New Mexico, is we try and find the best ideas and introduce them to scholars and practitioners from other parts of the world.
So at the Robert Wood Johnson Foundation, we're working with others throughout the country to build a national culture of health where everyone has the opportunity to live a healthier life.
So it's our hope that this is the start of working towards a healthier rural West.
So let's migrate on to a few slides now, and then we're going to have our panelists step up. Okay, so I have to push down. Okay, well, Badisha, seeing I do have a sense, I want to become an honorary feminist, so hopefully you notice the person riding the horse. And we're pretty proud of this person. So, and I had to take some diction lessons to make sure I got Yakima, because when I first said the word, I mispronounced it. I had a similar problem in Switzerland recently when I said Davos and it's Davos, but leaving that aside. So let's look at this. This goes back 70 years. Health is a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. So we spend a lot of time dealing more on the back end of life rather than the front end. And I think it's pretty important we do this. Now, if you look at a tale of America's rural health care, it's the best of times. There are unprecedented advances in medical technology. Treatments and pharmaceuticals can improve personal and population health. However, it's also the worst of times. The state of public health, unsustained health care costs, the quality of medical care delivered and access to services challenge clinical care and overall health. For you to go away with a quote that's not mine, it was put forth by a Muslim scholar, which I thoroughly believe in these times, if I is replaced by we, then illness migrates to willness. We, the people, working together, can collaborate to take on the crises and enhance the opportunity for sustainability. So I think we're in a very unique time in American history to go beyond just healthcare to better health, to a healthier world, especially in the rural West where we live. So it's pretty profound for me to go forward with a sense of purpose and vision and taking a risk on the challenge that all of us are involved in. With this, when we look at the American rural health landscape, we see a lot of issues that are all there. We see an aging population. We see the whole issue of payment models that are all over. We still haven't gone from fee-for-service to performance-based. We're having a real struggle getting that. We're having a hard time having practitioners abide by what critical choices put forth, evidence-based practices. So changing people's behavior is not easy. We have emergency technologies. There are about a couple million new apps out in the healthcare field. How many of you are familiar with all the different types of apps that are in there? It can be for dental, for mental, for Fitbit. And how many work and how many don't work, you don't have a clue. And how much education do you get in this? The overdose of information. Can you trust it? Is it credible? Is it transparent? So you go on, let me ask you a test question. If you go on the internet and you have a problem, what's the thing you find out first? The worst case scenario. So on a personal basis, I had a little change in the color of the urine. I went boom, boom, boom. I have end-stage urinary cancer. Right? That's not what I had, but that's what I saw, okay? So it's really a challenging time. You move on, and I'm really sensitive to time. Is this thing clicking? I'm pressing down here. Okay, there's another one. Okay, we can get through these. I want to make sure that the population has more time to talk. Can we get on to the next slide? You can work it so we just move the slides. I feel like I'm in Indianapolis now. Time is very precious on the racetrack. Okay, so rural health today, disparities due to, just fire up. Geography, demographics, socioeconomics, lack of providers, employment, culture, and education. They all go into what we call social disparity and the quest to get to health equity. Unfortunately, most of what we deal with is on the other side, on the illness side. We observe greater rates in the West of unhealthy behaviors, uninsured individuals suffering from life-threatening injuries. Incredible amount of people here because of the problem in getting to a class 1 or class 2 trauma center run into real problems and have a higher rate of deaths because of their accidents than elsewhere in the country. Moving forward. Getting started on health and healthcare transformation, which is critically important throughout our society, whether it's urban or not. Think broadly about the factors that influence health, sort of reverse the pyramid. 2, assess needs and resources that are available to you now. Could be on any other issue than just in health and healthcare, but it's critically important. 3, focus on what's most important so you can get a success early on and not study it to the end point, which may too long. So if the pollution's too high and there's asthma here, make sure people know how to use the appropriate mask, the appropriate medications and the like to take care of it for today and try to clean up the other issues over time. Choose the right policy and program for your community. It's very important, and we learned this at Stanford recently. You had to remain more than slightly humble, and the most important thing you can do is listen. Don't come into the community and think you're going to tell the community what to do. So if I come into Yakima, Yakima's got to tell me the story. So coming in yesterday, Yakima's got 60,000 people. Yakima's going through some economic issues. Yakima has some issue with crime rates among certain of the populations in town. The hospitals are pretty good. One hospital, there was Yakima Regional and Yakima Memorial, and how they fit into it. The supply of doctors is there, but it could be a little bit better. So this is a vibrant community that's going through its challenges like so many others. And if you look at it as in the rural area, we keep in mind that there's 17 states, which we define rural west. If we really want to be accurate, we make it 19 if we include Alaska and Hawaii. But you got to keep, each of these has its own cultures, each of its regions, and it's really quite important to understand how you're going to do this and listen to the people in doing it. The last one, engage a variety of stakeholders. And there's so many different stakeholders involved in all these issues. It's just not a doctor-patient issue. And if you have any kids who are millennials, you better not use the word patients. They're individuals. And if you don't learn to communicate, they ain't gonna listen to you. So as an old fart, I have to monitor my behavior with my millennial kids very much. Moving on. So key issues in transferring America's rural health care. Let's fire up. I'm running short. You can give me my sign in about 1 minute. Transitioning organizational focuses and capabilities to move from volume to value has to be done. Lowering costs while improving quality. Don't ever forget the triple aim. Better care, better quality at a fair cost. We're not there. New approaches to care delivery and patient relationships. Figure out where what used to be called artificial intelligence, or it's now called machine learning. Some people are changing to augmented intelligence. And if you're going to do something with innovation, do innovation with a purpose. Just don't say you're innovating. And make sure that disruptive technology makes sense. New approaches to care and delivery of patient relationships. I learned that many people, doctors, and I was there, weren't getting to their patients. And I would challenge a lot of the doctors. They didn't realize that a lot of the doctors, as they get past 60, are a little deaf. So they're not listening to their patients. And the patients are getting a little deaf. So you got two people talking to one another. And then many of the patients are so tired of when you go into the office, I've done this recently, all you do is your doctor's not looking at you, they're doing this on your technology. So you lack a personal relationship, and people really do value personal relationship, and satisfaction from the patient's perspective and the provider perspective are not always in sync. So try to find out what you're doing and what they want. Stakeholder alignment. Let's go. I think we're almost done. If not, we're going to turn it over. Improving the health of all rural Americans. Invest in the foundation of lifelong physical and mental well-being in our youngest children. Put more energy into that. Create communities that foster health-promoting behaviors, and broaden health care to promote health outside of the medical system. So I'm done with the slides. So in essence, this is to hopefully give you a background, and you will certainly be able to share with you in even more depth if you're interested. Now what's more important from my perspective is to hear our esteemed panelists, and our first panelist will be from the Washington State University, a health economist who's done some great stuff, is Badisha. Badisha, you're on stage.
So hello, I'm Badisha Mandal. I'm a health economist. Wow, it already skipped
Here you go.
quite a bit. Yes, oh, thanks. Okay. And I'm in Washington State University, and the main campus is in Pullman. So I'm located in Pullman, which is Eastern Washington, pretty much almost in Idaho, actually. My research and outreach efforts focus on understanding how public health policies affect health-related decision-making processes and health outcomes. And my target population, they are typically low-income households and residents in medically underserved areas. So for instance, one of my current research area looks at understanding healthcare utilization of Medicaid enrollees in terms of their emergency department use and inpatient admissions for chronic conditions. I think it's extremely important to collaborate with community stakeholders, because I don't believe one size fits all. So currently I'm working with Pullman Regional Hospital, which is the main hospital in Pullman. And when I say one size doesn't fit all, I'll give you an example. So even for a very well-defined problem, the solution, I think, has to be locally embedded. So how many of you have heard of the Oregon Health Insurance Lottery? A lot of you have. So a few years ago, Oregon did this experiment where they picked a few thousand individuals from low-income households, randomly chose half of them to receive Medicaid, and the other half did not. And then they tracked their healthcare utilization. These individuals were taken or were selected from Portland area, so from urban and suburban area. And what they found is that those who received Medicaid were using emergency department unnecessarily, much more than those who did not. Now, they don't know why that is. They have speculated it's because although the access improved, health did not improve. But if you now look at rural areas, we know, we have heard this many times, this is very evidence-based, that a lot of rural low-income households, especially rural Medicaid beneficiaries, also use ED a lot more. But what's surprising is that, sorry, I have not figured this out, is that high ED use does not necessarily mean that it's unnecessary when it comes to rural residents, okay? So that's what I mean by the problem is the same, ED use, but the reason and solutions could be different. So that's why I think it's important to understand what's happening locally and accordingly find a solution. So I will actually skip this slide. Like I said, I'm working with Medicaid enrollees. If you're interested, I can answer more questions later. I want to show you some findings from the Pullman Regional Hospital collaboration. So Pullman is considered a large rural area according to USDA's RUCA codes. And what I tried to do was look at readmissions, 30-day readmissions for chronic conditions, because with proper care, proper management, these things can be avoided. A readmission into the hospital within a month can be avoided for chronic conditions. So Pullman's is small, the hospital is small. I used 2 years of inpatient data, and there were 3,600 admissions. There were 138 cases of 30-day readmission, and then I just looked at a very conservative outcome. What were the reasons for 30-day readmission that is same as the original admission? Okay, so that the patient knows, the provider knows that the person is suffering from this chronic condition, and they're coming back to be readmitted in the hospital within 30 days for exactly the same reason. And these were some of the chronic conditions. So these, okay. No, actually, I wanted to go backwards. So anyway, I got it. So these are not going to be the same chronic condition in every hospital. I have looked at hospitals in Spokane, so the Providence. They will be different. So as chronic conditions are different, they are local, the type of solution has to be also different. One thing that is recommended or has been found to be very effective in lowering readmission is transitional care. So providing some sort of a support system as patients transition out of hospital to keep them out of another inpatient stay. So it could be a nurse, a practitioner, calling them to remind them that to take the medications, for follow-up visits, so on and so forth. These experiments, the findings, they have been from people who are recruited out of urban and suburban areas. We don't know how this will work, or if it will actually work if you have individuals in rural areas. So I'm kind of actually leaving this with a question that this is something to work on, to probably collaborate with local hospitals to find out what works for rural residents, urban residents, for the community. Thank you.
Thank you. Moving on, are we set? John, are you with us verbally, orally? Can we go see you live time? Yes, here we go. So our next speaker is John Mccarthy. He's a product of the Rural West, who's now the Assistant Dean at the University of Washington, who's deals with all the education programs for the Rural West for Wyoming, Washington, Alaska, Idaho, and Montana. And we got to know each other over the phone, and he couldn't make it down here today, but there he is. John, you're on.
Great, thanks. First test is, can you hear me okay?
Yes.
Yeah. Excellent, okay. Thanks, and thanks for having me, and I'm sorry I can't be there, but maybe as I go through my story, you'll understand why. So I'm gonna start with ticking me off, and I've got a brief PowerPoint that just allows some pictures of what I think I want to be showing. So, I entered medicine with a pretty clear direction of wanting to go somewhere rural. I was very interested in having the opportunity to work in a rural environment where I could do whatever I wanted to do, full scope medicine. And so that was my goal, was to achieve that. And I was able to do that by going to Tonasket. If I can get my screen working here. Maybe. There we go. And so that's a picture of where I lived. And it was exactly what I wanted to be doing, which was to be in a small area doing full spectrum medicine, having this kind of view out of my backyard, running a few animals, and it was a great situation, and I was well trained for that. And so I had the opportunity to work with wonderful people. You know, that was really what made it the best is the folks that I was working with. And I just appreciated that opportunity. And unfortunately, there came a point at which my wife said, we're leaving Tonasket. And I was aware that I was leaving my patients and I was leaving my colleagues, and that's very difficult in a rural area. I think that rural is disenfranchised at some level. They don't have the bells and whistles, and it kind of takes somebody with the desire that I had to move into that kind of an area, and there just weren't a lot of those. So what I did at that point was decide that I was going to figure out a way to get more colleagues out there, and I entered medical education, and I decided to work with the school that I'd been trained through, which was the University of Washington, which had training sites across the rural Northwest as well as the urban Northwest. And this is a map of some of those places that we do training at. And currently I'm the rural dean helping find people who want to work in these places. So the good news is that it's a good school, that it's been able to help with this, but it doesn't create enough students at all. And so I'm excited that PNWU and WSU, two collegial schools, are looking to do the same kind of thing because the workforce is not as robust as it needs to be. The reason I'm here in Spokane is because we're down to providers, and I can't spend the time to get away to come visit with you all right now. So, and I have two jobs. One's working for the University of Washington, and one is working for the Native Project Clinic that I'm currently at. So I decided, well, I'm gonna find my replacement. And indeed, I was able to find the woman who's driving her plow there. She was a woman from a small town in eastern Washington who knew how to drive a combine, and I said, this is the kind of person who's gonna be able to take over my job. And for literally the next 7 years, I mentored her in terms of getting back to Tonasket, and so that there would be somebody. And that's how long it took to get a physician back into my position so they were fully staffed. It took 7 years. And it was very intentional on my part to find somebody. I would have found somebody faster in the pipeline. I worked at both a residency as well as a medical school at that time, but there wasn't anybody that was going to get there faster in the pipeline. So what I want to do is kind of bring up 4 points, and very briefly, I got my 7 minutes and I realized how many I've gone through, and the first is that you've got to skate to where the puck is. You know, for you hockey fans, if anybody's from Canada, you'll understand this. And this world is changing very rapidly. And you have to predict what the future is going to look like. So when I started, there were no EMRs, there was no iPhone, there was no GPS, nobody had wearable devices, there was no hospitalists, there were no laborists, there were no remotists, there were no radiology being read from afar. So you have to be prescient in terms of saying, what can we do to make sure that we're promoting health and what our regions need. You know, 10 years ago, a small hospital was about $10 million to a small town. A single doctor was about $1.5 million to a small town. So economically, it makes sense to make sure that we're keeping the small towns viable. The small town I was in, if you didn't get care there, the next big center was 150, 200 miles away, and that was forever in a snowstorm more than once. So we have a commitment for the last 26 years, according to US News and World Report. We're the best rural training medical school, and we have programs that very intentionally are designed to get people out to rural areas. We have rural underserved opportunities programs, which drop students in for a month to see what the world's like. We take students who are interested in medical school and being in a small area before they even walk in the door at the big Seattle University or Spokane. They are walking out to a small community of 800-900 and seeing what practice is like there. And so we're very invested in feeding our pipeline. We think that's really important to make things work. I think in terms of creating doctors, this is just a brief map that shows this is where we've been able to do this. There are a couple thousand doctors across the Washington states where they've popped out on the backside, and a number of those are rural, and that's what we want to perpetuate. I think you have to have mentors for the students to be able to be successful. And I am not exaggerating in the least that I saw this young student who said, you know, I want to get back to a place where I can drive a combine. And 7 years later, she was able to do that. Thanks.
Thank you so very much, John. And you were really real, even though you weren't here physically. Moving on, Gabriel Garcia, who's from our team out of Palo Alto. Gabe?
John. So, down is forward. This is breakfast, and breakfast comes to you courtesy of Mexican hands at the field and Mexican hands at the restaurant. And so I'm going to talk to you about the Mexican hands in the fields. And I hope you develop a respect for why we're talking about this. And this is the kind of Mexican hands that are in the field giving us the breakfast that we got. And Rebecca Hester, who took this picture, my colleague, did it on a day when this woman's child was ill so that you could actually see her home. And her home is a tent in the field. And it's not that unusual a place where our Mexican and all of our agricultural field workers live. So we're going to talk about agricultural field workers as one of the least served by our rural health system, and try to think about how do we reframe our thinking of them so that we can in fact address their issues. And this is what Bonnie Bade's work, which was ethnographic, it was in the Imperial Valley, told us about them. And it's true then, it's true today. They're young, they're generally Mexican, they're Spanish speaking or speak an indigenous language. They're undocumented, they come as parents, they come as families, and they underuse social services because they're not there to use social services, they're there to actually earn money at the farm. And they're financially vulnerable. And they're financially vulnerable because their salaries are low. They have work that is seasonal. They have to move from place to work to place of work to earn their money. And very few of them hold one job all year. And so if we use the same poverty sort of measures as we use for the rest of the country, what we would find is about 2/3 of them are living in poverty. Their field work is dangerous, okay? Not only because of the injuries that we see in the field work, but also because of the chronic illnesses that actually come and disability that comes from the field work itself. Okay? And not only do the field workers do it, but their children, because of the environment in which they live in, frequently have malnutrition, vision problems, dental problems, etc., which lead to developmental problems. In the Scana Valley in the state of Washington, one of my colleagues, Seth Holmes, actually spent some time doing his PhD thesis in anthropology, studying the farm workers at Teneca Farms. And what he found in his interviews and in his work there, because he was picking berries for a year. Actually, if you ask Seth what he would say, what I found is that unskilled labor is not unskilled labor. That was the most unskilled labor in that farm. And that it's just how we value the work that's done. But what he did was he said, so what gives people an indoor job that's relatively easy to do, and what gives people a kneeling job picking berries that actually really ruins their body, really creates a series of occupational injuries for which these people really never get over. And if you think about the people at the highest levels and work of the farm that have the most respect, that have good health, that have financial security and control over their own time, they tend to have characteristics of citizenship, of English as a language, and in that particular farm they were of Anglo-American and Japanese-American ancestry. If you look at the people who are doing the kneeling and outdoor work, they tended to be undocumented, indigenous farmers, and mostly Mixteco or Triqui Mexicans. And it was a gradient. Everybody was somewhere in between as well. And so when we think about who's doing what work, we have to realize that the way that farm work is handed out is very socially structured and economically structured and structured by your legal status. And so if you are at the bottom of this scale, then you will in fact suffer the consequences of living a life of poor access and poor poverty. And a lot of it is through precarious living conditions, but also exploitative working conditions, low incomes, lack of health insurance. I think you know what's on this list. But the list replicates itself in pretty much every farm, or every large farm. And so one of the things that I did with my students this year, I teach a class that's about migration, poverty, and health, and it's taught on campus in Palo Alto, which is not a good place to experience it, but also in southern Mexico, in Oaxaca, where it is a good place to experience it, because Oaxacans in many ways are both the internal migrants of Mexico, as well as people who populate our farms as well. And they're doing a lot of the kneeling, picking berries work. And what we asked were very simple questions, and I'm going to ask them of you now, okay? Which is, how do you define wellness? Think about the time in your life when you had the most wellness, and the time in your life when you had the least. Those are simple questions. I want to give you 5 seconds to think about those. We entered very rural Mexico. And in a place where a community partner of mine was actually already doing some work, essentially talked to citizens. And the questions that came up, that is the references that they made in answers to these questions, was that finances were important, that social connectedness were important, that my role at work or at school was very important to me, and that mental health and physical health were important, and I just gave you the big pie. Now, there's no way that these aren't things that we all share as we look at what makes our wellness as well. And so we're dealing with people who actually we think of as different, but in fact have totally similar definitions to the way we define our own wellness as they define it. And so what we need to figure out is, how do we reframe our view of the migrant in our communities, in our receiving communities, so we actually treat them in the way that they would like to be treated. And this is my last slide. So my solution is actually that we reframe our view of migrants, and that we think of it not in a deficit mode, but we think of people that have to be flexible and adaptable and have a pragmatic approach. They have more resources than we do because they actually have the old way in which they did things and the new way in which they do things, and they can draw from either of the two to solve a problem. They take time to understand and adapt to their receiving environment because their survival depends on it. And they are connected, resourceful, and think of their social connections as the things that they, in fact, value the most. And if we look and frame their lives in a different state, then we're likely to, in fact, say, so how do we, in fact, serve this community in our midst in the best way that we can?
Thank you so very much. Our next presenter is Kevin. Kevin has an illustrious career both in the private sector as well as in the public sector. He's a senior facilitator. He's with the William Ruckelshaus Institute and has had some wins along the ways and probably some that he would define as work in progress.
Yeah, you can say failures. That's okay.
No,
Phil.
that's a California word. Nothing fails in Washington.
Is this audio working okay? Not too loud? Okay. So let me get the slide deck up. I am a facilitator and a process designer with the William D. Ruckelshaus Center, and I'm not going to burn up really much time talking to you about the center because Michael Kern and Craig are going to be on a panel later on today, and Michael will drill down in more depth in terms of what we do. But basically, just the elevator speech real quick is we are a university-based center co-hosted between Washington State University and University of Washington. And we act as neutral facilitators and process designers around big, wicked public policy issues. So our goal is to improve the way that policy is made, especially in large, multi-party, multi-sectoral areas. My background is in health policy, but given Bill Ruckelshaus and Michael's backgrounds, we have a lot of legacy work in the environmental and natural resource sectors. So I come from a 30-year background of working, as Phil mentioned, in the private sector for the public sector. All of my group's clients were state Medicaid agencies, and I've had the privilege, the headache, and the heartache of working with Medicaid populations in 40 states over the last 30 years. And all states have a rural component to them. That is policy design and program implementation work. So when we take a look at, I don't have too many slides. I have about 2 more slides, and that's about it. But when we start to look at policy work and the work that we did around developing rate reimbursement methodologies to pay all the providers in the state for Medicaid, you really get a better appreciation for why Medicaid is so important. It really is, as they say, the state laboratories in this country. And when we talk about progress that's been made up until now in terms of the way that healthcare is delivered, the triple or quadruple aim, and basically trying to figure out how to deliver the right care in the right place at the right time at the right price. A lot easier said than done. And I know there's been a lot of background material in this, so I won't belabor that. But I kind of wanted to just sort of go back to a 10,000-foot level without getting hopefully too wonkish on you, and talk about from a policy perspective, where we are. And so Medicaid has always led. We also worked on dual eligible populations, which are those folks who are both dually eligible for Medicaid and Medicare. And the reason that's important is because they tend to represent disproportionately a much higher cost population with many more comorbidities. And as we move further into integration, the hot topic in terms of integration around behavioral health and physical health, and we start looking at social determinants of health and whether those are important and whether they're properly financed in the system to incent new behavior. I titled this slide Backdrop for Systems Change. So this is not systems change from, let's say, a hospital or provider's perspective of getting more throughput, patients through your hospital faster. We're talking about systems change with a large S. So what's going to be done to move the needle in the sense of we've got all this federal money and with state match, because Medicaid is a partnership program between states and the feds. And we've done a lot of initiatives and a lot of federal demonstrations over the years. And we've experimented in a lot of states in a lot of different areas. And where there have been successes, those have been replicated, but they aren't always scalable to larger populations. So Phil put up slides at the beginning that really ticked off a lot of different areas, and I want to get into a couple of those. We are now in a system with a capital S that, in my opinion, is, for better or worse, really, it's not a judgment, because I'm a neutral, is becoming more and more hospital-based. So hospital systems, through mergers and acquisitions, have acquired many physician practices over the years. It's been going on for 15 years and continues. So you end up with basically fewer players across systems. And that has different meanings in rural areas. So when we start looking at very rural areas, and Yakima area is about about a quarter of a million people in the larger areas. So I'm not sure that we would define this area as rural, but there are a lot of rural issues everywhere. When we start looking at hospitals in very rural areas, whether they're community hospitals or critical access hospitals, you find they've been struggling for a very, very long time in many, many areas. Those hospitals are often economic generators for those smaller rural areas. They employ a lot of people. And there's often a lot of civic pride. And I've worked in states like the Dakotas where, towns are literally drying up and dying off. And towns will still hang on to their hospitals because of those reasons. So you may end up with rural area hospitals that are now meant to be all things to all people in that area. And maybe that's the only option that they have. And they are absolutely bleeding red financially, and they can't fill their beds, but they're still around. And I'm not saying that they shouldn't be. I'm saying that they might be a lot more, and that's the aspirational part of this that we'll end up with. The other point I wanted to talk about was workforce development, and we've all heard the age wave stories, and we can all watch that, or we can look around this room and see a fair amount of gray hair, and myself included. And really take a look at, when we talk about technology and we talk about apps and things like that, how are we really going to solve these gaps? The medical schools can't pump out enough physicians to be able to solve these gaps. There aren't currently enough physician assistants and nurse practitioners and other extenders all the way down to community health workers that can necessarily fill these gaps unless we have a larger systems change in place, is my point, and in my humble opinion. I think when we talk about the best care at the right time in the best place, we really need to think long and hard about how we're going to fill those gaps and how we're going to break down those silos, and that really gets us into the collaborative governance piece. So the money really represents the financing and the complexity of the financing around these programs that are still fragmented. So we have a system now that becomes very, very hospital-centric, and Yakima's got really strong folks. Mike is going to speak in a couple minutes, and he represents a clinic-based primary care system here, one of three, that really supplement and provide the safety net for this whole area. And so when we talk about the financing, we talk about value-based purchasing, we talk about moves away from fee-for-service to try and get into a better use of paying for quality. Whether that ends up being a global payment that's payer agnostic, so no longer have the stigma of being a Medicaid patient versus a Medicare or private pay patient, whether we can get the private pay system to speed up to the level of experiments and frontier level that Medicaid and Medicare have taken on around lots of acronyms, accountable care organizations, patient-centered medical home models. These are all places to try and treat person-centered care, to try and focus more on the patient. And lastly, the social determinants of health. And I really wanted to spend just an extra minute on that. But if you take a look at this, and this really originated, I think, with University of Wisconsin's great work, but was picked up by the CDC and National Institutes of Health. And really, it's I don't think the numbers are precise yet, but the message out of this is that your genes and biology, your genetic code probably means less to your ultimate lifetime healthcare outcomes than your zip code. And so when we look at that in a little more detail, and that's a little hard to read, but when we look at this physical and psychosocial determinants of health, a lot of things that others have talked about so far on this panel, we start looking at community, we start looking at built environments, we start looking at your education, food, not in the sense of food availability, but in the sense of nutritional scarcity. We look at trauma-informed care, and we look at the trauma that's placed on children in our society and what that means to your life expectancy and what that means to the cost of healthcare and the delivery of healthcare. These are all areas that are still very, very siloed. We're really at the frontier. We're working very hard to bring collaborative efforts, and that's really my goal at the Ruckelshaus Center, because my job wasn't challenging enough before. So healthcare is really pretty backwards. There's no systemic use of collaborative capacity building, consensus building types of processes. And that's what we're working on very hard to further draw these silos down, to be able to get stakeholders and other interested parties together and away from the turf wars and more towards collaborative solutions. So I'm pretty optimistic about that. Thank you.
Thank you. Thank you so very much. And it's nice that we have people who can maintain neutral. That's not one of my personalities. So, whatever. Our next presentator is the local, my personal physician, Mike. Yep. You're my personal physician in Yakima, so take your job seriously.
So I don't need that thing because I don't have any slides, which is a good thing. My neck needs a rest. Welcome to Yakima. So Yakima's been my home for 35 years, essentially my entire professional life. From that perspective, I want to tell you, I would view on March 23rd snow in Yakima to be an extreme weather event. So given some of the other topics at this conference, which I'm happy to be participating in, I think that may be appropriate. I don't know. So I mentioned already, I've spent my entire professional career here, but here I am talking about rural health issues. But I think that's actually true of every panelist here. Now, like Dr. McCarthy, John McCarthy, I too am a family doctor. Unlike John, I've never practiced rural. And that's really part of what I want to talk about is the paradox of rural health, is that how often communities are dependent upon outsiders who are looking in, but really do have their interests at heart and want to help, but it's not always easy to help them. So how do we do that? Kevin's the one who recommended me to the conference committee to be a part of this discussion, so thank you, Kevin. And I think the reason Kevin did that is that we've had some association, and he was aware of some of what I've done from my perch here in Yakima around working for rural health. And so just briefly, some of those things have been being the founding director of a family medicine residency program that has operated here in Yakima for 25 years and also operates a rural training satellite. But for all 25 years, we've had a strong mission to place graduated family physicians in rural and underserved communities in this region, and that has worked pretty well. Also creating a migrant and community health center here in Yakima that has developed 4 clinics serving rural communities around our area, the 2-county area here in northwest Yakima County and in Kittitas County, in some of the smallest communities in the county. And also having been a founding director or a member of the Board of Trustees of Pacific Northwest University, which you'll hear more about soon, which is having a major impact on health workforce for the rural region. But I am an example, like the rest of us, of the paradox that we don't live what we promote. The rural communities welcome our interest and what we can bring, but they also can be a little skeptical. A lot of my perspective on that comes from the fact that I grew up 3 miles outside of a town of 350, 200 miles north of here, on a ranch, 3 miles of dirt road, we had a phone. It was 5556, our 12-party line. Ours was 2 shorts and a long. And if there was a rite of passage in my community, it was fighting forest fires. And back in the day, most of us lied about our age so we could get out and get to it. For a variety of reasons, I never practiced rural. But I still hold that value. It's certainly part of what I've always wanted to serve. I also grew up revering our family doctor, who was in the town 10 miles away. And as I grew older, I came to recognize the sacrifices that he made to have the career he had. But I also recognized, and it was very painful to recognize, that he was quite often very underappreciated in his own community. And that really was painful. I think a lot of towns, and sometimes the people in them, are a little bit like W.C. Fields. He said, I wouldn't want to belong to a club that would have me as a member. So kind of like, well, if it's a doctor that would come to my town, they must not be much of a doctor. That attitude. I also heard that in practice here in Yakima, in things like discharging a tribal member from the hospital and sending them for follow-up at the Indian Health Service clinic, and hearing them tell me, well, I don't want to go there. The only doctor that the government would send me would be a horse doctor, and that's a quote. So it can be a struggle. On the one hand, they do want the help. On the other hand, they can be very suspicious of strangers bearing gifts. But I'm as guilty as anybody of being provincial. I'll tell a story about Roger Rosenblatt, who, if there are other students of rural health in this community, you'll recognize that name. He was one of my mentors throughout medical school and residency, and he made enormous contributions to the understanding of rural health systems and improving rural health care delivery. But throughout that time, I could never quite get over the fact that he had never actually done that. I'll never forget being in the audience when he was receiving an award from the Washington Academy of Family Physicians for his work. And he opened his acceptance speech with these words: "I am a complete fraud." And my esteem for Roger, I always held him in high esteem, but my esteem immediately shot up because it told me this wasn't a mea culpa. It was a very lighthearted acknowledgement of the fact that this paradox exists, and that a lot of what's happening to try to help rural health systems is happening from urban and academic environments. From that perspective and from that history, there are just a couple of things, actually 4 things, that I wanted to share that I think are helpful when approaching rural communities. One is humility. We don't have all the answers, and no answer is right for every community. Second is appreciation. Most of these communities are doing things, have achieved things, and no matter how modest, it probably happened with a lot of effort and a lot of sacrifice in those communities. Third is inquiry, really seeking first to understand, listening actively and understanding what's going on in that community. And the fourth is low expectations. I think if you are in approaching a community, if you have something to bring, very quickly the question is going to come up, what is this going to require of us? And if the answer can be very little, you have a leg up. And if you have that leg up and you can start something in that community and have a low expectations, start small, build something, build commitment, build trust, build the recognition of value, you really have something that you can build on together with the community and move forward. And that's worked for us. So, thank you.
Thank you. And our last speaker, just to make sure the score is appropriately noted, it's a fellow New Yorker, Bruce. So we got 2-1 on you. So take it away, Tom.
The screen is a little small, as Phil so graciously pointed out, that physicians over 60 can't hear very well and they can't see very well, so I'm going to move over to the podium over here. That was my only joke, and I got nothing out of that. This is an unbelievable group here.
Yeah, well, I almost fell off, but that's okay.
Well, I know if you push me off that I'm overtime.
Here you go.
Thank you, that's good. I still can't see it, but thank you. Okay, yeah. I'm Tom Scana Dallas. I'm the Dean of the College of Osteopathic Medicine at Pacific Northwest University of Health Sciences here in Yakima. And our president, Dr. Keith Watson, is here as well with me. I guess first thing is, everybody knows what a DO is? I'm not seeing 100%. So here's the deal. There's this long-winded explanation I won't get into. So I tell this little story as a vignette to help people understand where we're coming from. When I was training in New York hospitals, the surgeon would tell me, go see the gallbladder in room 301, which I envision a gallbladder in a jar on a shelf in a room. Osteopathic medicine, we train our students to go see Mrs. Smith, who is frightened. The surgeon should say she's got a presumptive diagnosis of cholecystitis. She has scheduled for a lap chole tomorrow morning. She's frightened out of her mind. Her family is frightened for her. Her friend had the same procedure and almost died, okay? She has a job in which the family is dependent upon her income. So unless you consider all the different variables and factors internally and externally that has an effect on a person, they're not going to attain wellness. And so we talk about health of the patient, customer, what was the word now?
Consumer.
Consumer. Family's health, community's health. Unless all those things are in sync, an individual is not going to attain optimal wellness. The university was chartered in 2005 because of the physician shortage. In Washington and the Northwest, rank at the bottom in terms of physicians per capita. And to add to that, in the Northwest, there are 4,000 physicians aged 60 or older, so that's going to add to this critical shortage. The university's medical school seated its first class in 2008, a class of 70. They graduated in 2012, and in 2013, the first class of 135 was seated. We're the second medical school in Washington at that time, and the first in 60 years. And since then, WSU has seated their first class last August. We're teaching focused in most large university medical schools. They have University Hospital across the street, for which the clinicians come across to lecture a few times a year. They're not very good at it. In large institutions with a large research infrastructure, the scientists come out of their lab for a few lectures a year, and they're not very good at it. We have a modest infrastructure for research and clinical care, and so our faculty are focused full-time on teaching. And so this is something we value, and it's a great resource to have someone who is focused on the education of our students. I have to point it someplace. I am, the down. Oh, it could be upside down. Thank you. The other down. As you can see, our female to male ratio is 5-to-1, and we assume there'll be a lot more male applicants in the near future because of this. No, we have about, that's the second joke, but thank you for laughing. We've got about a 50-50 mix every year across the 6 years we've had graduating classes. We have a diverse class, and they really learn from each other. The university also now is planning for its own new programs. We just got regional accreditation, so we're having consultants do feasibility studies with us on occupational therapy, physical therapy, mental health counseling and primary care, and dental medicine. So you'll be seeing some more programs coming out of PNWU. We currently have a cohort of PharmD students from WSU on campus. We have a cohort of PA students from Heritage University on campus, as well as nursing. So we're very involved with interprofessional education in a meaningful way, because that's the way these physicians and healthcare providers are going to interact in the future. The mission is really about training students to become osteopathic physicians to provide research-driven quality care to communities of the Northwest, particularly in rural and medically underserved populations. We have a heavy focus on primary care, and we're very successful at that. Dr. McCarthy pointed out the high ranking for primary care in the University of Washington as judged by the U.S. News and World Report. I will note that I was recently named by U.S. News and World Report as the sexiest man alive. So it must be true. And even a clap, this is getting better. Okay. So how are we going to accomplish putting more physicians into rural and medically underserved areas of Washington and the Northwest? Well, this is our strategy: recruit, educate, return. Recruit locally and regionally, educate them locally and regionally, and bring them back to the communities they came from. We don't recruit from New York or Boston or Chicago or Philadelphia. If that would be the case, they would come here for 2 years, spend a third year in one of our regional sites, then do their electives in their fourth year back home, and their residencies back in those areas, and they'd return to practice there, except maybe to Philadelphia. So we've got, our distribution is almost 80% of our students come from Washington, Alaska, Oregon, Idaho, and Montana. We've got some bordering states there, and I do know that California is not a bordering state, but it borders Oregon, and Oregon borders Washington. And about 12% from other states, okay? So we recruit locally for a reason. Many of the students, when they talk about why they came, talk about growing up in a rural area and driving 30 miles or 50 miles to see a physician, and they want to do something about that. You know, in New York, I was there for 25 years, the New York Institute of Technology, College of Osteopathic Medicine, and all the applicants would say, I want to practice primary care in a rural and underserved area. Okay? Well, here our students actually mean that, and you're going to see the numbers that stay here to practice. Now, after you finish 4 years of medical school, you have to do residency training, and it's very competitive these days. And in fact, there's not enough spots for all U.S. grads of MD and DO schools and the offshore schools. And so every year, there's about 1,000 U.S. grads from medical schools that don't get residency. Okay? So for a new school, that was fairly daunting. So how are we doing? 100% match rate every single year of the 6 graduating. This is phenomenal, and it really speaks to the quality both of our students as well as our faculty. Getting to the primary care, family medicine, internal medicine, and pediatrics, we exceed the national average every year except one. I don't know what happened to that class in 2015. I had just been here 2 years. Perhaps they thought out of respect they would go into sports medicine like the old man. I don't know. But we've done very well. If you add generalist categories, okay, general surgery, emergency medicine, OBGYN, and psych, which are also in critical shortage here, we average about 80 to 85% of our students go into those residencies because they're needed here as well. Where they do their residency, okay, you can see that 34% of our students do residencies in the Northwest. That doesn't seem to be exceptional unless you know that there's only 2.6% of all residency training positions in the Northwest. So they want to train here. So the others go in other states, 66%. Well, you probably heard the statistics that about 60% of residents who finish their training practice within 100 miles of where they train. So why, then, are students coming back to practice? And I'll get to that slide. In fact, I have 30 seconds, and I'll get right to it. You can see they're from medically underserved areas, from rural areas, from health professional shortage areas in high percentages. This is where their graduates come from, the Northwest local. We've got almost 500 alumni now. Most of them are still in residency or fellowship training. And here's the number. 75%, even though they train in the Midwest and Northeast, come back to practice in the Northwest. We're very proud of that, and we hope to sustain that. So at that point, I'll conclude. I've come to my point here, so thank you for your attention.
Thank you so very much, Tom. Make sure you get off. So to stay on time schedule, maybe take another 5 minutes from our luncheon break since we have such quality here. Let me start by asking the panelists to pose a question to one of the other panelists because there's been no interaction. So if someone said something that you challenge or differ or want to add to, anyone's willing to step up and take a shot at one of the other panelists? Mike, you look like you're ready. You don't have a single, so you agree with everything everyone said? John, you have anything you want to say long distance? Ask anyone? He's giving you a thumbs down? I thought you'd give a thumbs up.
Okay, what do we make of that?
He's having a little trouble hearing, so. You having trouble? Do you have anything that you want to ask a question of anyone else on the panel? Otherwise, we're turning it over to the audience.
You know, one question that I would have, and all of us that are well versed in this appreciate the economics of medicine and trying to keep local people local. It's just really difficult to do this. I think the way to attract students to, or recently graduated physicians to a practice in a rural area is to run a dating service. And I'm really not kidding. In terms of what makes people go to smaller places, or what allows them to do it is a relational life that's going to work. And so you may go to Seattle and find a spouse there, and so you were hoping to get back to Davenport, Washington, but your spouse is a Seattle spouse because you were training in a surgery program that you can't train in anywhere else besides Seattle in the state of Washington. So I think that's part of the dilemma that we face. And it's, $500,000 to train somebody as a resident into a full-fledged doc.
Hey, does anyone want to talk about Match.com?
Yeah.
Anyone have on the panel would like to be responsive to John's inquiry about dating and matchmaking?
Well, it's absolutely true, and it's as true here as it is in, and although this is not rural, as it is in rural communities, and we're always recruiting the couple.
Okay, well, that's a good response. Thank you, John. Gabe, you had a question you wanted to ask?
So the question I had was with the pie chart that you showed in the social determinants of health. And I look at it a little differently. I think to put social and economic together is probably not the way the original pie chart artist actually did it, just social environment. Because economics actually affects all of the pieces of the pie. And so you would say, does biology depend on economics? And now as we learn more about what growing up in poverty does to early childhood development, the answer is surely yes.
Sure.
And so I want to just move that piece of the pie to just talk about social environment, because if you really start looking at root causes, it's about power, privilege, and economics.
I think that's a great point. And I would also say, based on Mike's comments and what Gabriel put up on his slides, that maybe to further Mike's comments and John's comments around economic development, because economic development is suffering in rural areas. And as populations are dropping in rural areas, and many of us are getting older, coupled with the economic development challenges, it's very, very difficult. I've been facilitating a group here in Yakima for the last year, which includes Mike and his group, and Keith Watson and PNWU has been the sponsor on this and have been very gracious in bringing this together. And we've been talking about one of the issues is, how do you deal with, these are all problems, but how do you deal with primary care doc shortages? How do you deal with emergency room compression and the exhaustion of emergency room docs, because people are going to the emergency room for sore throats and stuffy noses? How do you build up a rural area? And maybe there's an opportunity, because Seattle's gotten so expensive, and even those of you from the Bay Area and the LA basin will recognize from long past what it means to have property values go like this. So if you open up the Seattle Times every Saturday, you will see Yakima advertisements for cheaper housing out here. So how do you work through those issues? Maybe the people at the table collaboratively should include people outside of the clinical medical bubble, and we've talked about this in our group, and include bringing in chambers of commerce folks and other leaders.
Let's open up to the floor, because Kevin's promised us he'll have all those hows, he'll have the answers of why and when shortly. So we look forward to all your solutions. From the floor, especially the ones I can't see over here, we must have a couple of questions about you, personal health, your population health, your public health. Craig, we got one here, hiding. Who? Okay, sure.
We need to get microphones to people because we're recording.
There you go.
First off, I'd just like to thank Stanford and the Bill Lane Center and the Eccles family for promoting this event and bringing everybody together in this group. So thank you very much. My name is Stuart Wodsworth. My wife is Kim Ha Wodsworth, an active Stanford alumni and a present student at PNWU, and has on Friday found out that she will be training at Central Washington Family Medicine, which also is here in Yakima, Washington. Being from the Bay Area and involved in that environment, we had reservations about coming to Yakima, being a smaller community. I'm not sure we're going to leave now. So my question is to Dr. Scana Dallas and Maples is, how can this community in Stanford, academic and government, help promote the mission of Pacific Northwest University as it relates to staffing rural America with medical professionals?
Mike, you want that one?
So how can Yakima?
Well, Stanford.
Oh.
The government institutions in Washington and Washington State help promote the goal of attaining medical professionals in rural West.
She could write a large check to Stanford.
Yeah.
That might help.
We are annual donors, but
yeah, I guess the nuance of that, I'm not sure I can speak to. I think the thing that maybe is important to speak to is that think about it. Against all odds, I mean, was this not ultimate hubris for a place like Yakima to think that they could start their own medical school? But here we are. And you've seen Tom's report, and you've seen the success of the school, and in a very mission-focused and methodical way about that, to respond to what is clearly demand. Tom didn't talk about the number of applicants for those spots, even and clearly there was the winnowing of that pool was very mission-focused to have achieved the results that they are achieving. So I think it's a great example of what can be done with that kind of a focus. The other thing is, as to the diversity of the class, a lot of the folks that are in undersupply in terms of representing the population that we would like to get into medical careers lead lives that are fairly place-bound. They're bound to family, they're bound to land, to community. So the prospect of somebody, a lot of folks from the Central Washington area picking up and even moving to Seattle is kind of a non-starter. So you took something that might have been an aspiration that seemed unattainable and made it seem attainable. So I think that's an important piece of the success here is not asking people to pick up and plop into a metropolitan environment that they're not comfortable with.
Pat, you had a question?
Yeah, it seems to me that modern medicine, like academia, has become so specialized that the left hand often doesn't know what the right hand knows or how to communicate. I've had a kidney problem, so I went to the kidney doctor, and he was giving me all this stuff. So I said, hold on. And I got two other doctors that I consulted with on the phone, so we actually had a conference. What are we going to be doing to get a better integration of that process? And one small follow-up question. When half of America's children under the age of 12 are obese or bordering on obesity, what are the medical schools doing about elementary education on public health?
Like, I can address the latter question first. I got the mic. We've got outreach programs partially because of establishing a pipeline, particularly for underrepresented peoples, to be able to get medical education or health professions education. So we go down to the second grade classroom at Barge Lincoln and start exactly on that topic about obesity and healthy eating and lifestyles and those kind of things. We've got a program called Roots to Wings, where we work with middle and high school students from the Yakima Nation Tribal School. And we have a co-mentoring program in which they work with our medical students and they learn from each other. As also a pipeline and also as service. We're community and service oriented. And I think the education is the framework. Okay? If you have a society or a community that doesn't have high education or high health, you're not going to have good outcomes for your health indicators. And so the education is a prime important piece of this, as well as the access to physicians, which we're trying to accomplish.
Two points on that one just real quickly. Tulane Medical School and Mount Sinai School now both have cooking classes for their physician training. So they're bringing kitchens in to teach them what's the appropriate cooking should be for the future generation. The second one is a comment you made earlier when you were talking about wildfire suppression. It should be for the entire health field, which used to be doing public service and getting credit for it to help you with your tuition expenses. So if you go out in the community, you get some rebate, and I would say I did that in the public health service and it worked quite fine. So that's the way you could get more support either on, and there are certain states that are beginning to support the medical education process, but with a payback clause to it. Sure.
To get to the first part of your question, I would agree. The HITECH Act, which was federal law that threw billions of dollars at forcing practices into certified medical records, has been a failure. Yeah, they're all in those products, but they aren't talking to each other. Yes, they're all on the same standard, but that doesn't make them communicate. So there's still so much work to be done there, and overcoming those obstacles is far greater than was imagined when they created that law.
Okay, we got room for two more questions from the audience.
Actually,
anyone want to step up? We got one. I didn't miss you.
I have one more comment on this. So it turns out that when you create all of the data flow from a clinical encounter, a physician generally makes his or her own decision about patient care using only about 0.7% of all of the data that's available, a very small amount. And so, yes, we have things that catalog and report, but we don't have things that actually provide a clinician who needs to make a decision with only the information that he or she needs to make that decision at the point of service in a timely way. And interoperability, that is the ability of that, when you create a system that was actually on a business model rather than on a service model, it just wasn't there.
Our last but not least question is yours.
The question for Dr. Garcia. Are you seeing or do you anticipate impacts on migrant health as a result of the current administration's deportation practices? I know certainly Obama deported a lot of people as well. My sense is that the culture, the rhetoric, if not the numbers and practices, are a little bit different under the current administration. Do you have any thoughts on how that might impact migrants' health?
I think the fear factor has increased because of the rhetoric, but I'm not sure whether in fact there's going to be more people deported necessarily as a result of what we've seen throughout this time. But certainly decreasing the willingness to access care and actually relying in the same way that they would in the traditional community, that you might go to your town healer first before you go to a medicine healer first, is something that's being practiced in today's communities that are rural, particularly among the indigenous communities, and will continue to do so, I think, to a greater extent.
Well, let me start thanking all the panelists, including John. Good luck with your mating service that you're creating on your sideline. Thanks to all here, the august population here, and to all of you. And as we said last year, I said this is not the start nor the finish. We're all involved to convene, collaborate, and commit to a better rural West. So thank you so very much.